Thank you very much. Thank you for the introduction and for the kind invitation. I'm very excited to be here, and congratulations on the very, very lively and interactive format of this conference. So in the next little while, I'll be talking about preventing IVH in preterm infants. And this will be our roadmap. So we'll start talking about a little bit about IVH, its mechanisms and its risk factors, short and long-term consequences, how high-quality delivery room and postnatal care can help prevent IVH. We'll talk about, obviously, pharmacological prophylaxis and head position and IVH. And then we'll end up by talking about neonatal care bundles to prevent IVH, very exciting and controversial topic, I think. And I'll try to finish with some take-home messages. So germinal matrix hemorrhage or intraventricular hemorrhage is a complication that happens in up to 25% of babies less than 1,500 grams. And the lower the gestational age, the higher the risk. It usually originates from the germinal matrix, which is this very highly vascularized subventricular area where the progenitor cells multiply and then move on to the cortex. And there's remnants of germinal matrix in preterm infants, especially in the caudothalamic notch, and that's where most germinal matrix hemorrhages and intraventricular hemorrhages originate. Choroid plexus hemorrhage can also happen, but it's less common. So the contributing factors for GMH or IVH are mainly the fragile nature of the germinal matrix microvasculature, and also fluctuations in cerebral blood flow and the lack of cerebral autoregulation, cerebral blood flow autoregulation. Periventricular hemorrhagic infarction is a complication of germinal matrix hemorrhage, and it's due to collapse, compression of the collector vein by a bleed in the germinal matrix or intraventricular. And this compression, this collapse leads to congestion of the medullary veins and to venous infarction in the periventricular white matter. So other than low gestational age, what are the risk factors for IVH? There are some prenatal risk factors or protective factors, depending on how you present it. So lack of antenatal steroids is a clear risk factor, and it's probably related to chorioamnionitis or preeclampsia, although there's not much strong evidence to support this association. And regarding perinatal risk factors, I don't think there's an influence by the mode of delivery. There doesn't seem to be an impact by the mode of delivery or by delayed cord clamping, though this is recommended for other beneficial reasons. Though cord milking is associated with an increased risk of IVH, so this practice should be avoided. Regarding postnatal risk factors, we know that being born outside a tertiary center and being transported in an ambulance is a risk factor for IVH. Also, classic morbidities, hemodynamic instability, RDS, mechanical ventilation, pneumothorax, bicarbonate therapies also should be avoided. Hypothermia on admission, coagulopathy, and thrombocytopenia. There are also some genetic risk factors, namely COL4A1 mutation. So you probably all know about the classification of IVH. So we call it grade 1 when the bleed is subependymal and it's not filling the ventricles. You see this small bleed in the caudothalamic notch. When there's blood inside the ventricle that occupies less than 50% of the ventricular size and that doesn't cause acute distension of the ventricles, we call it grade 2. And we call it grade 3 when there's a large clot enlarging the ventricles like you see in this example. We should avoid the term grade 4 IVH, and we prefer to use the term periventricular hemorrhagic infarction. This can be associated to any degree of IVH. And also grade 4, I think, implies the blood dissecting the tissue and invading the parenchyma, and this is not what happens. What happens is an infarction, a venous infarction due to compression of the collector vein. Post-hemorrhagic ventricular dilatation is a complication of IVH, and it happens in about a fourth of the cases of intraventricular hemorrhage. And the higher the grade of IVH, the higher the risk of post-hemorrhagic ventricular dilatation. And this is more or less a natural history of post-hemorrhagic ventricular dilatation. So about half of the cases will stop dilatation either spontaneously or after some temporizing measures. There's some mortality, and there's also about a third, maybe a little bit less with early intervention of babies needing VP shunt, a permanent shunt. So the risk of long-term adverse outcomes depends on some risk factors. It's higher in babies that are in lower gestation age, less than 25 weeks, with severe IVH, grade 3 or parenteral hemorrhagic infarction, or those developing post-hemorrhagic ventricular dilatation needing a permanent shunt placement. Grade 3 and post-hemorrhagic parenteral hemorrhagic infarction associate a risk of adverse neurodevelopmental outcomes, especially adverse motor outcomes. So you see that the odds ratio for cerebral palsy is nearly 5 compared to baseline risk. There's also a risk for adverse cognitive outcomes. And what about grade 1 and 2 IVH? There's been debate whether this is equal to nothing, to having no IVH at all, or whether it's a risk factor, and it indeed seems to increase the risk somewhat of adverse outcomes in combination, moderate severe neurodevelopmental impairment, and also abnormal motor and cognitive outcomes. So in terms of preventing IVH, we can think of aspects of general neonatal care, obstetric care, perinatal and postnatal care. So we want to promote the use of antenatal steroids, and we want to recognize and treat intrauterine infection. And then in terms of perinatal and postnatal management, we want to ensure high quality delivery and postnatal care for very preterm neonates. We want to provide adequate respiratory and hemodynamic support, and we want to avoid abrupt physiologic fluctuations, hypoxemia, hypo or hypercapnia, hypo or hypertension, and we want to avoid abrupt fluctuations in cerebral blood flow. So key aspects in this are delivery room resuscitation, respiratory support, hemodynamic support, treatment of thrombocytopenia or coagulopathy, and adequate management of PDA, whatever we think that is, which I think has been addressed before in the meeting. So here's the first poll question for you to answer regarding the prevention of IVH. There's no single cause or preventive measure. There's no magic bullet. Nursing care bundles have not been provided effective. Maintaining an elevated supine position of the head in the midline reduces the risk of IVH, or indomethacin reduces the risk of IVH and adverse long-term neurological outcomes. Okay, I think this is very good. So a bit like in everything in neonatal care and in medicine in general, there's no magic bullet, and there's a lot of hope for head positioning. We'll address this in a minute. So regarding pharmacologic prophylactic IV indomethacin for preventing IVH, this has been a long, hot topic. And there's a meta-analysis, a rather old meta-analysis now from 2010 that shows that prophylactic indomethacin does indeed reduce the risk of severe IVH, grade 3 and parenteral hemorrhagic infarction, but it doesn't reduce death or the combination of death or severe neurosensory impairment. I think it's difficult to tackle why it doesn't reduce this adverse outcome when it does reduce the neurological morbidity during the neonatal period. And one of the possibilities might be the effects of the actual drug of indomethacin on cerebral perfusion. And what about head positioning and cerebral blood flow? Well, we know that the turning of the head to one side does occlude to some extent the jugular venous drainage of that side, and it increases the cerebral blood volume. Supine midline position with the bed tilted 15 to 30 degrees is associated with improved cerebral venous drainage. And how do we achieve this supine midline position? And this is related to previous talks on really good neonatal care, including kangaroo care, like we heard before. So in the supine position, you can align the head with the midline, and in prone position, that is not possible. You have to turn the head to one side, and head midline position is not feasible. And there's a lot of interest in the position during kangaroo care. So you can do kangaroo care on lateral position with the head aligned with the midline, like you see in this picture. And this has been improved with associated with improved neuromotor outcome in small studies that have been recently published. And what about larger data sets? In meta-analysis, head position has not been associated with a lower risk of any grade of IVH or severe IVH. Mortality might be reduced according to this Cochrane systematic review from 2020, but there might be an influence of cot tilting, which is a co-intervention in many of the studies in some of the studies that were included in this systematic review. And this is some pictures from the guideline from Oxford University Hospitals, where I used to work for some years before I moved back to Barcelona, showing some of the nursing care recommendations to try and prevent IVH. And this is related to head positioning and preventing IVH bundles in general. So impaired venous drainage and decreased cerebral tissue oxygenation are known risk factors for IVH. And most IVH preventing bundles do recommend midline head positioning during early transitional period, first 2-3 days after birth. However, this is not based on strong evidence, but on expert opinion, and it's always mentioned as a potential better practice. These are, as I say, some pictures from Oxford where there's recommendations about how to position the baby when they're lying in the incubator, trying to keep the head aligned with the body, and also with an inclination of the incubator of 15 degrees. And what's been published about neonatal care bundles? Well, there's this nice study from the Netherlands. This is a multi-center study, a cohort study that included 281 babies less than 30 weeks. And the bundle consisted on a combination of caring to maintain the head aligned with the midline, tilt the incubator 15 to 30 degrees, avoid head down position and sudden elevation of the legs, especially during nappy changes, and also avoiding rapid IV infusions or arterial flushes less than 30 seconds. In this study, the risk of, or the rate of GMH or IVH of any degree combined with PVL or death, and also the combination of severe IVH, PVL, or death were reduced with the implementation of this care bundle. And this is another study from the United States where they implemented a package of primary and secondary drivers to try to reduce the risk of IVH. And this was done over a long time period. Their baseline risk of severe IVH, or the combination of death and severe IVH, was rather high at the start. And they did manage to reduce the risk so the combination of severe IVH or death was reduced from 27% to 15% during a long time period. And also severe IVH was reduced from 16% to 10% during this period. And drivers that seem more significant were wise bicarbonate use or avoiding bicarbonate use, also in the medicine, and targeting of CO2. So next question for the audience. If you want to reduce your rates of IVH in your unit, first you need to be aware of your actual rate. Are you aware of how many of your babies have this complication in your unit? Or is it data that is not open to you? Okay, so most of you do, but still 20%, 25% of people do not know their baseline rate. So please go back to your units and look at it, and to try to make quality improvement, you need to know the start of the story. And then the next question, do you have any experience with care bundles to prevent IVH? Have you done any quality improvement work in your unit of this nature? No? Okay. Okay, so a lot of you haven't, and I'll show you that we have. This is small data from multi-center data, so please take it with a pinch of salt. But this is us. So this is we take part in the Vermont Oxford network, which you probably know that this is a benchmarking network of over 50,000 babies born less than 1,500 grams across the world. And this network gives you the rates of different neonatal morbidities, and it gives you the mean rate and also the interquartile range. And this yellow line is my center. So we don't have very, very many very low birth weight infants. We have a little bit less than 100 a year. So the numbers are small, and small changes will make big changes in rates. So please be cautious about this interpretation. But anyhow, we were above the 75th centile. And moreover, in 2017, we became worried about this increase in our trend, and we wanted to curb that. So we worked on a care bundle to try and reduce the incidence of severe IVH in preterm infants. In 2018, this was a collaborative work led by my colleague Ruth Del Rio, who kindly shared the data and the nature of the work. So she leads the very preterm infant working group, and also our pharmacists collaborated, and also the neonatal neurology group, which I belong to, work to think of the elements of the bundle that we wanted to implement. So we did some standardization of care. Basically, we made a bit more of a system about admission, blood test being taken from the umbilical cord, and also about the order set. So we had an EPR embedded admission order sets for less than 1,000 grams, babies born less than 1,000 grams. We also got more non-invasive TCO2 monitoring devices, and we did that in all ventilated babies. And then we also did a lot of work with the nurses to take some time to be able to do cares between two people in the first few days of life for babies less than 1,000 grams. The biggest change was that we implemented prophylactic indomethacin for babies less than 1,000 grams, but not all of them. The higher risk ones, the ones that needed mechanical ventilation, or the ones that didn't have prenatal steroids. So in the end, it's small numbers of babies receiving pharmacological prophylaxis. And then Ruth and the rest of the group did an analysis of cases with severe IVH. We took this as a sentinel event, and we did a root cause analysis in every case. So what do you think happened in our unit? Well, this is what happened. So remember, we are the yellow line. We were trending up. And then during the implementation of the bundle, we were really happy because we saw a decrease in IVH. But then if we continue to look over time, then we're back up at the 75 centile. 2023 is not closed yet, so we're still including babies that have been born at the end of the year or have had a long admission. It looks promising, but I wonder if this is really an improvement or not. So with quality improvement projects, you have always the question of whether you're having Hawthorne effect, so whether by having an intense watch of a certain set of cares and a certain set of outcomes, people are behaving better than normal, and then they forget. And then another thing that happened in our unit is that we opened a new unit, and we had to hire a lot of new nursing staff. So we have to kind of go back and retrain and do the work on how to implement this bundle with this new members of staff. So this is a nonstop continuous work. So I'd like to finish here by giving you some take-home messages. So the risk of IVH is mainly associated with lower gestational age. Aim for high-quality delivery room and postnatal care to improve babies' outcomes in general, and IVH in particular. There's no single preventive measure for IVH and its long-term consequences. And multiple practices seem to cumulatively change and lower the risk of IVH, even if individual practices may not be effective in randomized controlled trials. So bundles are varied, and depending on a unit, some things may be more or less effective. And I wonder if they're effective at all, or this is something completely coincidental and cultural. But in any case, there is a room for reviewing your outcomes, reviewing your results, and promoting continuous improvement. So thank you very much for your attention, and I'm open for questions.